Hi, my name is Becky Sanders. I am the Program Director for the Upper Midwest Telehealth Resource Center. Thank you for joining us today. We are recording today's session. We will post it on the UMTRC YouTube page. We will also post the link to the recording on our UMTRC archived webinars page, as well as a PDF version of the slides after today's event. You will receive a link to this when it is posted on the UMTRC website, and that will be in the next couple of days. So without further ado, I'm going to pass everything off to Natalie Stewart from Purdue Healthcare Advisors, who is going to introduce our speaker today. Thank you.
Thank you, Becky. My name is Natalie Stewart, and I am the Assistant Director for Quality Services with Purdue Healthcare Advisors. And I'm pleased to introduce my colleague, Patty Rose, who's a Senior Advisor in Quality Services. She's our subject matter expert on everything having to do with MIPS and promoting interoperability, which is formerly meaningful use. She has extensive background with office management, medical office management, billing, coding, and back when there was the old PQRS program, she was a subject matter expert in that as well. She is passionate about telehealth and using it to support office-based practices. And she's here today to tell you about using telehealth and telemedicine to support your MIPS and Medicaid promoting interoperability achievement moving forward this year. So I'm going to pass it off to Patty and let her take it.
Great. Thanks, Natalie and Becky, and welcome everyone. And I've got a lot to cover in a short time, so buckle up, and I tend to talk fast. So if you have any questions, hold them to the end, and I will be more than happy to help and answer those. So we're here today to talk a little bit about MIPS and the Medicaid PI incentive programs for 2020 and how that all ties into telehealth. So there's a little snap of who you're talking to today, and I've been with Purdue for about 6 years now, and so now they gave you a little scoop of what I do and where I come from, so we'll jump right in. So our agenda for today, like I said, we're kind of do a quick overview of the MIPS and MUPI. We here at Purdue like to call it MUPI, which is Medicaid Promoting Interoperability. Do a little overview of telehealth, how the two telehealth, telemedicine can improve our scores for MIPS and MUPI, and then some tips for success, and talk a little post-COVID and telehealth, and of course resources. So jumping right in, quick overview of MIPS, which is the Merit-Based Incentive Program. There are 4 performance categories. Hopefully most of you know those by now. This is our 4th year of MIPS reporting. There's the quality, cost, improvement activities, and promoting interoperability. So the 4, they are each weighted differently. The quality is rated 45% of your MIPS score, cost 15, improvement 15, and PI 25, which you add those all together, your MIPS final score 100%. Quality and cost, the first 2 categories, those are a full year, started January 1st to 2020 to the end of December of 2020. And then your PI and your IA is any minimum continuous 90-day period. Most folks lean towards the 4th quarter, but there are a few that it may, maybe July, that 3rd quarter. So, and then you must, you're certified EHR, electronic health reporting technology, you must be on 2015 and 2020. The deadline to submit your calendar year data for 2020 is March 31st. Oops, going backwards. And then I want to talk a little bit about the payment adjustments. I kind of like this pictorial. It shows you the performance year, which right now we're in 2020, as in 2019, which most of you probably wrapped up reporting for calendar year 2019, March, April there. But for 2019, as you can see, the incentive positive penalty, it was 7%. Started at 4% in 2017. The rule of thumb is that the performance year, let's say 2019, the penalty or incentive would hit your Medicare Part B allowables January 1st of 2021. So you'll either get a negative or positive incentive, and of course, 7%, that sounds like, wow, 9% for 2020 for this year. But there's a little thing called budget neutrality that CMS has. So it's it depends on how many people attest to the program and how many that don't. So if you have a lot of doctors that are attesting successfully, your incentive is going to go down. And if there's not so many that are attesting, then the penalties will hit and then your incentive will go up for successfully reporting. So anyway, just a little snapshot. Hopefully most of you know that by now. Going backwards. This is another talking about payment adjustments. In 2019, the minimum amount of points that you needed to avoid a penalty was 30. Now for 2020, that minimum increased to a minimum of 45 points in the MIPS program to avoid the penalty. So between 45 to 84 points, you're going to avoid the penalty and you'll be eligible for a slight incentive. And then if you're 85 or more points, you'll be eligible for a possible 9% incentive, and there's this exceptional bonus of up to 10%. Again, that all depends on that budget neutrality. Keep going backwards. And then what's new, like I mentioned, from 30 to 45, that threshold, you have to get 45 points to avoid the penalty in 2020. The exceptional performance, again, went from 75 to 85. And for the quality measures or your objectives, there were 43 quality measures that were removed, 4 measures added, 82 updated. Cost has, category has 10 additional episode-based measures, bringing a total of 20. And then improvement activities, there were 2 new, actually 3, and we'll talk more of that here later, 15 removed and 7 were updated. And then for group, if you're any of you out there that participate in MIPS as a group, which CMS defines a group as 2 or more providers. If you're reporting as a group for improvement activities, it's just not one provider doing improvement. You have to have 50% of the group. So if you have 10 providers in your group, 10 of them have to be doing improvement activities. Hopefully the whole group, everybody's doing improvement activities, but just kind of, that's a little change for 2020. And then for PI, they removed the verify opioid treatment measure, but they kept the query a prescription drug monitoring program. E-prescribing, I like this little snapshot. There are 4, not e-prescribing, but for your Medicare PI, there are 4 objectives under Medicare promoting interoperability. You have e-prescribing, health information, provider to patient exchange, and the public health. There are some exclusions on this one for ERXing and the HIE. If you have less than 100 in your denominator during the reporting period, you can exclude for that. And again, the reporting period is any 90 days, whatever 90 days you're reporting on. If you have less than 100, you can exclude, because that's been a really tough one for a lot of folks to meet. And then security risk assessment I've listed is not listed here as an objective, but you have to have it. It must be done. And then I kind of highlighted in red that provider to patient exchange, because we'll talk about that objective a little more in depth later in the presentation, because that ties into telehealth. And then of course, at the bottom of your screen, I have the 2020 link to the PI measures for 2020. And then here as a snapshot of the Medicaid promoting interoperability, or like I mentioned, we here at Purdue like to call it MUPI affectionately. There are 8 objectives in the Medicaid program. Protect health information, which is your security risk assessment. Hopefully by now, those of you that are out there that report your Medicaid, you're familiar with these. I'm not going to go through each one, but patient electronic access to health information and coordination of care, number 5 and 6. Those are all portal objectives, and those are tied into telehealth. And again, we'll talk more in depth on how you use those for telehealth and improve your MIPS score. And of course, I provided the link at the bottom there that'll take you directly to your Medicaid MUPI specifications for 2020. And then for MUPI for 2020, the reporting period, pretty much the same as Medicare MIPS program, as any continuous 90 days in 2020 for all Medicaid EPs. You have to do electronic clinical quality measures, or ECQMs, which 6 EQMs, a minimum of 6, within your scope of practice, and at least one of them have to be an outcome measure, again, for a minimum of 90 days. And then you must have your 2015 cert for the full 90-day period, I should say. Again, your security assessment, you have to have it done at any time in 2020. So you don't have to wait to the 4th quarter. If that's your reporting period, you can have it done now if you want, as long as your vendor is up to 2015 specs. And then Medicaid is kind of wrapping up here. 2021 is the last year to report MUPI. Medicaid attestations must be submitted by September, October of 2020, or 21 rather. More information is forthcoming on this. I know they just wrapped up the attestation period, the end of April for Medicaids. So stay tuned for that going forward. And then now to jump in a quick overview of telehealth and telemedicine. So what is telehealth and telemedicine? The two, by now, hopefully you're a little bit familiar, but the two words are used interchangeably. They mean pretty much the same thing, but use of electronic information and telecommunication technologies to support long-distance clinical healthcare for patients. So that's the formal definition. Why does it matter? Telehealth has obviously been really big lately because of the public health emergency or COVID. So why does it matter? Cost effective. You're going to save some money on having those patients come into the office. During COVID, reimbursements, a lot of people aren't coming out because of the pandemic. And so to stay safe, they're going to use telehealth. So follow-up visits, and then CCM and TCM, which is chronic care management and transitional care management. Perhaps some of you are already utilizing these programs in your offices, but these are telehealth, and these two programs are really key. They really can benefit if you're doing chronic care management and transitional care for telehealth. Medication management, if you're using telehealth and you have a visit with a patient and they forgot their medication list, they can hold up their bottle of the pills and you can see what they're taking. It's a better way to manage meds over the phone. You don't have to have them come in the office quicker. Improve patient satisfaction, underserved and rural areas. It's very convenient. Transportation, a lot of folks have a hard time getting transportation to come into the office. So it's a perk if you offer telehealth. Convenient of your home. You're sitting on your couch talking to your provider. How cool is that? Preventive disease. That's huge, obviously, during this time. Doctors, staff want to stay safe. Elderly patient, those are high risk. They want to stay safe. So seeing your doctor and getting health care from your home remotely is huge. Again, spoke a little bit about revenue opportunities. There's not a lot. That has been the big holdback or barrier to telehealth in the past because Medicare and commercial payers did not reimburse real well. Well, that has changed since the flexibilities of the pandemic have happened with telehealth. Improves clinical quality and patient outcomes. That's just clear that you can improve the quality of care you provide. Maybe patients are more apt to talk more freely and openly with the provider via telehealth from their own home. And then provider patient safety, I kind of mentioned that one already. Keeping everyone safe is really key. And then here's a few of the most common types of telehealth out there. Live video conferencing, what we think of interaction between your provider and maybe your smartphone. You're now talking to your provider and your smartphone. That two-way audio, visual, and real time. They like the term that telehealth users use is asynchronous, which is real live video. And then there's store and forward, which is more referred to sometimes as asynchronous. Basically, data that's transmitted electronically on the patient outside of real time. Maybe you took a picture of a rash you were having and you sent it to your provider, sending that data to your provider, not having a face-to-face visit. And then remote patient monitoring, maybe a lot of you are already familiar with this. Real data patients monitoring, like health monitors. They've been doing that for a long time for pacemakers. Maybe your patient has a health monitor and you can transmit that data electronically via remote patient monitoring. And then mobile health or mHealth. Smartphone apps, so many smartphone apps out there. Think of it as, maybe you have a heart disease and there's a smartphone app that allows the users to access your cardiovascular disease data. And then it helps you, the app would identify locations in your zip code area that you can go have your glucose checked or your pulse checked, and then other physiological parameters. So just some different types of telehealth. And then as I talked about the flexibilities that the public health emergency has offered for telehealth, the Office of Civil Rights, or OCR, back in the middle of March there, they announced the enforcement of HIPAA rules, that they're not going to be enforcing them. They're not going to come out and audit you if you're not providing telehealth in the way that, in good HIPAA standards, but good faith, that make sure that you're doing the best you can to provide telehealth services to your providers and secure I mean, you always want to, your patient is number one. You want to make sure that they're safe and their data is safe. There is a OCR Telehealth HIPAA FAQ. I've provided a link at the bottom of the slide. It has a lot of good stuff in it. I love FAQs. They often answer a lot of my questions, so I want to make sure to list that for your reference. And then again, back to the OCR flexibilities. Permitted non-public communication technology includes Apple FaceTime, Facebook Messenger video chat, Google Hangouts. I have some family that is using Google Hangouts for behavioral health visits. And this is just temporary during the public health emergency, but hopefully long-term this will stick, so to speak. Indiana law, again, I'm from Indiana with Purdue, so I'm basically talking Indiana. There may be a few listeners out there in other states, but Indiana law requires all video conferencing to be secure. So good faith, make sure you're doing your best possible, and don't use something like, this is prohibited technology, like Facebook Live or TikTok. You know, the doctor does a little dance on TikTok while he's seeing his patient. So those things are not secure and are not recommended to use. Some more about telehealth as the Medicare expands coverage for telehealth during the pandemic. You can have patients can be in their home, and it's not just for rural areas anymore. Consents, this is real important. This can be done by the staff or the practitioner at any time. It only has to be done one time a year. You can do it verbally. You know, you're got on the phone, maybe your staff starts the office visit for a telehealth visit, you know, Mrs. Smith, I want to make sure that you're aware of their telehealth services, or offer it through your portal. You know, maybe you send a pre-visit text or email, you know, make sure you log into our portal and sign the consent and understand all the secure regulations for telehealth visits. Again, patients in rural settings, maybe there are folks that don't have access to internet, or maybe don't have a smartphone or not technologically savvy. CMS did an awesome thing late March that they said, yes, you can do a telephone only evaluation and management visit for either a new or established. And pre-COVID, those rules weren't there. So this was a huge win. So if you have your older provider or older patients in a rural setting that aren't comfortable doing a telehealth visit, you know, with the audio visual or synchronous, they could do just a phone visit. And then lastly, if you are a rural health clinic or a FQHC, they also can provide telehealth with greater flexibilities. And that kind of leads me into my next slide here, which talks about MLN Matters. CMS came out with a new guidelines for FQHCs and rural health clinics. They had one that came out mid-April, was only 4 pages, but then they revised it as of April 30th, and this is 7 pages. So if you haven't seen this already, highly recommend. I provided the link at the bottom of the slide here for you to reference that. Good stuff, a lot of great information for FQHCs. And then I want to roll right into coding. I'm not going to go into depth in coding. I'm not a certified coder, but I know enough to be dangerous. But I think it's important for you to be aware of the codes that are out there, because they do tie into the MIPS reporting and what you can report for quality measures. So I'm just for telehealth and audio and visual. Again, I mentioned new or established patient. There is the option to waive copays during this public health emergency. And then some E&M codes I've listed there. Most frequent, you know, 99213, most of us do that everyday office visits. And now though they could be paid again with a modifier, and I won't go into modifier detail, but I provided a link at the bottom to the Indiana State Medical Association, ISMA's COVID site. Highly recommend to check this out if you haven't already. There's a lot of good stuff. If you scroll down, you go to a provider area, and it has these decision trees that the last one I believe was updated May 11th. Excellent tool for you if you're struggling with how to code correctly for your telehealth services. But again, check it out. Virtual check-ins, check-ins, phone calls, store and forward, no location restrictions, and then there's just a couple of the codes that you can use for virtual check-ins. And then e-visits, which is secure messaging or answering a patient's questions through your portal. You can bill for those too based on time. And again, more guidance and directive are provided at the ISMA's website, the decision trees that they've provided for you. And then a couple more here, a telephone only, like I mentioned, CMS says, yeah, telephone only will be paid now. And so there's a list of the codes that apply, and then mobile health services, again, based on time, how much time you're spent with that patient must document, real important. And then the link for ISMA's decision tree. And then the end of March, CMS also came out with an additional 80 codes that they will cover under telehealth. And you could see temporary edition for the PHE or public health emergency. And I've provided a link at the bottom that'll take you directly to a list of those codes if you're not aware of those. And then finally, what we've been waiting for, how can telehealth benefit my MIPS and Medicaid scores for 2020? So just kind of want to highlight a little snapshot again. This is I've got on the top half, the MIPS categories, and the bottom, I've talked about Medicaid measures. So quality, there are quality measures that tie in with telehealth. Improvement activities, I believe there's about 3 of them, and then promoting operability. We'll talk about some measures under the promoting interoperability category. And then for the Medicaid or MUPI program, there's patient electronic access to health information and coordination of care through patient engagement. We'll talk a little bit more about those two, how those tie into telehealth. So the first one we'll start out with is the objective number 5 for Medicaid or MUPI. Patient electronic access to health information. So this basically is providing your patients timely access to their health information and patient-specific education. Now, I know a lot of folks in Indiana struggled with meeting this objective in 2019 because of that second, there's 2 measures wrapped up into one. That second one, the 35% of all patients are provided electronic access to clinically relevant patient education resources during the reporting period. That was a hard one for a lot of folks to meet. It's been hard across the board to get patients engaged in portal use. It's gotten better, you know, just like online banking. It took a lot of time for folks to get used to that online banking, and now that's the only way we do banking anymore for the most part. But anyway, and so the first part of this objective is 80% of your patients that are seen by your provider. They have to be provided timely access to view, download, transmit, or VDT to their health info. And you must ensure patients' health information is available for patient to access via any application of their choice via an API. Now that API is the application programming interface. And I want to give a little tip here. Make sure that you work with your vendor on this one. We had some vendors this past 2019 that functionality was not turned on at the beginning of the reporting period. And then that provider wasn't able to report that measure because they didn't turn it on in the background. So having that API functionality available, and must be, some vendors require it to be turned on. So just kind of a little helpful tip there. And these APIs, some vendors offer an API, maybe they have one already pre-chosen for you that you can recommend, you know, your patients to use. But if that patient shows up at your front desk and like, oh, I have an API I want to use, you have to be able to get them connected. So again, more deeper dive, I could go on forever, but deeper dive into this objective, I provided the link at the bottom that takes you directly to the specification document that gets into more detail on this objective. And then at the bottom, I have listed exclusions. If you have no office visits during reporting period, or you do not have broadband available, which I think there's only 1 or 2 states in the whole United States that don't have broadband. So really doesn't apply. Most people have office visits, but just kind of want to throw that there. And again, you can do a deeper dive into specs at the link below. And then objective number 6, coordination of care through patient engagement. Again, this is a patient portal objective. Basically using your EHR, certified electronic health record technology, to actively engage with patients about their care. On this one, again, 3 measures wrapped up into one. The first one, there's 3 of them, but you have to meet 2 of the thresholds, attest to all 3, but meet 2 of the thresholds for this objective. So the first one is more than 5% of unique patients are actively engaged in your EHR via view, download, transmit, access health info via the API, and or a combo of the 2. And then the second one, more than 5% patients secure message was sent or received, and it has to be clinically related. So either that patient sent a message to you via your portal, or you sent them a message. So real important. Again, I provided a link at the bottom to do a deeper dive into that objective for more detail. And then the third piece to this objective number 6 is more than 5% of your patient generated health data or data from non-clinical setting is incorporated into your cert. And you're like, what is non-clinical setting? So I provided some examples. Social service data, advanced directives, medical device data, home health monitoring, fitness monitoring. Maybe some of you have, you know, the Apple Watch or Fitbits, and that is considered a non-clinical setting. A long-term care coordination of care data. All that needs to be generated into your EHR. And again, more specifics are on the link below. But this is, I wanted to point this non-clinical because this is in telehealth. This is how you can utilize this particular objective number 6 if you're doing telehealth in your office. So this can improve your score, you know, giving your patients more reason to get engaged with your portal. It's all about patient engagement and educating them. So again, I could talk for longer on that, but I won't. I'll just skip on to, now we're switching gears. We're into the Medicare or the Merit-Based Incentive Program PI for telehealth. And that particular objective is also portal related, is providing patients electronic access to their health information. Again, pretty much same as the Medicaid program, view, download, transmit, making sure they have timely access. And again, double check with your vendor because every vendor is a little bit different. Sometimes just logging into your portal doesn't count as viewing. You have to do some more steps. So real important to work with your vendor on this particular objective as well. And then make sure you ensure your patient's health information is available to access via any application, that API functionality or application program interface. And again, some of your vendors may offer a particular API functionality within your cert. Again, work with your vendor. And then, you know, a little bit, I'll go into some more on how does telehealth improve the scores. So, you know, this gives a reason, like I mentioned earlier, a reason for your patients to log into the portal. It's a win for, you know, that if you're using a telehealth, maybe like the consents I mentioned early, maybe, you know, email your patient before their telehealth visit and sign our consent. Go onto our portal and you can read this, you know, what the consent says and, you know, to agree to portal. Patient education, encourage patients to use that portal, form, signing consent, and then education. So, and then there is a link at the bottom here that provides more specific information on the this provider to patient engaged measure as well. And then we're going to roll into quality category. How can quality, and this is kind of where a lot of the telehealth ties into our quality measures. There's over 219 quality measures that are available. You have to have a minimum of 6 measures with one outcome or high priority. And I always recommend my clients to choose, you know, 9 or 10 as a safety net, but a minimum of 6 measures. You have to have the full reporting year, January through December, and data completeness. A lot of folks struggle with this one. What is data completeness? In 2019, it was 60%. Each of your quality measures had to have a 60% data completeness. Now for 2020, it ramped up to 70%. Basically, data completeness is, you know, you need to report, which means that you need to report performance or exclusion exception data for at least 70% of your patients that are eligible for the measure's denominator. Each measure is going to be a little different. So take a step back and make sure, you know, not only meeting it, but maybe make sure you're documenting correctly if that patient is excluded or if there's an exception for that particular patient. So 60 to 70, good to know. A little screenshot here, it might be a little blurry, but this is from the 2020 Quality Quick Start Guide. Highly recommend to download it. Got a lot of great information in it. If you're new to quality or even if you're old, good stuff. They provide a lot of hyperlinks. The collection type talks this one, the particular screenshot talks about ECQMs and MIPS clinical quality measures or MIPS CQMs. CMS changed the verbiage on us last year where it used to be CQMs for registry or MIPS registry quality measures. Now it's just MIPS CQMs. What's the difference? Maybe you asked. ECQMs are pulled from your EHR electronically. It's a structured field within your EHR. And then the MIPS CQMs is more of a manual process. You know, maybe you have to manually extract data from it. So just think of ECQMs, electronic, don't have to do anything. CQMs, you may have to do a little work. So again, check with your vendor how they report your quality. They may have the functionality to report the quality measures for you. And then here's a little snapshot. These are the codes we kind of talked about a little bit earlier, the different types of telehealth visits and then the coding that correlates with it. I just wanted to point this out that there are, drum roll, over 130 CQMs that are tied into these codes off the spec sheets. And you're probably wondering, well, how do I figure that out? And I'm going into the next slide. Well, first I want a couple more slides. I'll talk about that. But this one shows a little snapshot of the CQM. These are the CMS CQM numbers that are excluded from telehealth. We're going to look at particular 317, and you're thinking, well, what is number 317? If you're like me, I don't have the CQM IDs memorized. So you go to the QPPCMS.gov website. I provided the link there. Hopefully that is a favorite and you go there often. They've got a lot of awesome information. Click on the MIPS in the upper right-hand corner, and it goes down to, you can see where the quality measures is in the menu. Click onto that, and then it opens up another set of screens, and you want to make sure you can see they have tabbed out there 2017, 2018, choose 2019, and then scroll down a little bit where you can explore measures. From here, you'll see I took a couple screenshots here of what you'll see. You can search by, verbiage of the particular quality measure, smoking cessation or blood pressure. And then they have other drop-down boxes where you can choose the collection type. And then I blew up the collection type screen here where the drop-down shows you can choose which collection type are you reporting your quality measures. Electronic clinical quality measure, ECQMs, or MIPS CQMs, which are probably two of the most popular. So you choose which reporting collection type you're doing. And then they'll pop up this particular objective for 317, preventive care and screening for high blood pressure and follow-up document. And then if you look here, the highlight box there, they have the blue hyperlink. So they have your collection type listed. If you're doing claims reporting, there are a few folks out there that are still doing paper claims. Then you have your ECQMs and MIPS. So you want to, whatever reporting or collection type method that you're using, you can just click on that spec sheet, the blue hyperlink for that, and it will bring up, and here we are, quality ID number 317. This is a specification sheet for this measure, screening for high blood pressure and follow-up. And then took another little screenshot where you could see, if you scroll through the document, you will see the encounter codes. These are the codes that are covered for this particular measure. And this one particularly has without telehealth modifiers. So quality number 317 for screening for high blood pressure is not one you want to use if you're thinking, hey, I'm got all these measures shows, I'm going to get some extra points for using telehealth for this quality measure. Well, for this particular one, it doesn't apply to telehealth. So just kind of want to point that out, how that works. And then this one is a spec sheet that I accessed that is included in telehealth. So if you're reporting measure number quality ID 370, depression remission at 12 months, this is included in telehealth. So, and you can, I've highlighted in the little red box, the CPT codes 99421 through 99444. Those are all encounter codes that are listed in the telehealth. Temporarily again, hopefully long-term, it will be covered after or post-COVID, I like to call it. So just a little snapshot of what you want to look for when you're looking at your spec sheets and what you're reporting. And then I want to highlight, discovered a little, this is a qualified certified registry out there, MIPS Pro. And in the lower box at the bottom here, we do not have any kind of financial tie to MIPS Pro, but they had a cool little functionality where they offered, as you can see in the red box here, 2020 telehealth related MIPS quality scores, and then non-telehealth related MIPS quality measures. And this is free. You don't have to have be registered with them or anything. It's able for anyone to use. This is another resource you could go if you're wanting to find out if the quality measures that you're reporting, you can benefit from using telehealth as well. And then I provided the link to the actual website at the bottom as well. And then improvement activities, telehealth and improvement activities. The first improvement activity I want to speak on is the EPA 2, which is use of telehealth services that expand practice access. And this is weighted at medium. And what I mean by weighted, in the bottom gold box, I've kind of listed out some tips on IAs. Remember, improvement activities is only a 90-day reporting period out of this year. There are 40 points possible. If you're a large practice, what CMS considers a large practice, if you have 15 or more providers, improvement activity that is weighted medium is worth 10 points. And if you have an improvement activity that is weighted high, is 20 points. However, if you are a small practice, non-patient facing, or if you are a clinician, your provider is in a HPSA, which is a health provider shortage area, the improvement activity, if it's medium, it's worth 20. And if it's high, it's worth 40. So technically you can only, if you're small, if you fit any of that criteria for a small practice, and you choose a high weighted improvement activity, you could get 40 points and you're done. You don't have to report anymore. And then at the bottom, I supplied a link to the improvement activities for 2020. And then the second one, improvement activity that's kind of tied to telehealth is this one, which is anticoagulant management improvements. And again, this one is weighted at medium. So depending on if you're small or large, normally it's 10 points. If you're small, then you would get 20 points for this one. So eligible clinicians that are prescribing anticoagulation meds must attest to 70% of their patients receiving these meds are managed with support from one of more of the following IAs. So the 5 bullet points that I have listed here, you have to be doing, if you're doing anticoagulation meds within your practice, one of these. And again, deeper dive into the actual objective, go into the link that I provided below or on the previous slide for improvement activities. But rural remote patients are managed using remote monitoring or telehealth options. So you may be doing this telehealth and not even knowing it, that you're actually doing an improvement activity. So this is a great improvement activity if you're doing telehealth. And then the new one that was recently added because of the public health emergency is COVID clinical trials. So if you are a MIPS clinician and you're seeing COVID patients, you could be you could use this improvement activity if you're using a clinical trial like they've listed here, CMS, Oracle's COVID-19 therapeutic learning system. And then if you're participating in clinical trials such as being conducted by the National Institutes of Health. And then again, I provided a link at the bottom of the screen, and then there'll be some more information in my resource page at the end of the presentation, but gives you more information on these clinical trials, which ones. So again, if you're providing, and this is high weighted, so if you're a small provider and you're doing, I keep pointing at the screen, if you're a provider that are seeing COVID patients, oh, I got a message. Oh, I need to shut that down. Sorry about that, folks. But it's high weighted, so you can get 20 points if you're small for this particular one. At the bottom of your screen, if you can, this one can be paired with improvement activity ERP2, which is participation in a 60-day or greater effort to support domestic or international humanitarian needs, which we are. We're in a pandemic, so you could utilize this one and tie it into the ERP3 for the clinical trials. And this is all COVID telehealth related. This is just a little snapshot of what the specification sheet looks like for clinical trials. And they have a validation in there, what you need to prove. Because at the time of attestation for your improvement activities, it's just basically a yes or no. So what do you do in the background to audit proof your improvement? Yes, I'm doing this one. How do I prove to CMS if audited that I'm actually doing it? So to validate, you could do a proof of participation in the COVID-19 clinical trial, doing a screenshot. Take a screenshot to prove, and then it has also listed the suggested documentation that needed to prove, if audited, if you're doing that one, this particular one. So good stuff. Again, that link was provided to you in the resource page to this. And then tips for success. How can we, I talked a little bit about this already, but you could run a report of all your patients that are high risk, chronic care management patients, and reach out to them via telehealth. How are you doing, Mrs. Smith? And you'd be surprised. I've had several clients that have already done this before, just as COVID started. What do we do? Patients aren't coming in. How do we check on our patients? You're building a relationship with that patient also. Patients like, wow, this doctor really cares for me. So you're reaching out to your high-risk patients. You can bill for that too. A check-ins, telephone check-in, depending on 5 to 10 minutes. There are timeline constraints, particular codes. Also, online support groups. If you have, if you're an office that treats a lot of diabetes mellitus patients, you can, have a support group. Maybe you have folks that want to get together on the phone and talk about, education, dietary needs, smoking cessation. Big one. talking to a patient over the phone about smoking cessation. And then 12 steps program. That could also be done during online support via telehealth. Kind of talked about chronic care management, transitional care management already. They can be billed during the same reporting period, yet they fulfill two distinct needs. And these are all telehealth related as well. And then quality measures, we just got done talking about that. Review your quality measures. Go to those couple resource connections I listed here and make sure that the quality measures that you are reporting, maybe there's a few in there that you would benefit from providing your telehealth services for the last couple months. Long term, like I said, this is here to stay. I don't think it's going away, but the time will tell. And then educate your patients. I know we sound like a broken record, but providing education to your patients on, using your portal, getting those email addresses when patients visit the office. Or if you're doing a telehealth visit, Mrs. Smith, I just want to make sure we have your correct email address. All those things help success, not only MIPS, but with your benefiting from your telehealth services that you may be providing. Future of telehealth, we don't know. Like I said, time's going to tell. I really like these, my little graphics down there. I don't know, maybe I'm dating myself, but I don't know, maybe some of you remember the Jetsons cartoon back in the 70s. I was just a little girl back then, so maybe some of you weren't even born. But anyway, the Jetsons were doing telehealth visits with doctors back then. This was in the 70s. So, now we're in the 2020s, and look how far we've come. So anyway, it's kind of funny. But Seema Verma, who is our CMS administrator, recently, was quoted by saying in an article in Becker's Hospital Review, I think the genie's out of the bottle on this one. I think it's fair to say that the advent of telehealth has just been completely accelerated, and it's taken this crisis to push us to new frontier, and there's absolutely no going back. So if you haven't implemented telehealth already, I think you need to step back and take a look. I think the benefits are going to be there long term. CMS is supporting it. There's been a lot of grants and awards out there to help increase the telehealth usage. And so I think it's here to stay, folks. Good stuff. And then lastly, do you ever feel like you're chasing your tail and trying to keep up with all this? I mean, it changes from day to day. I get tired, just like you do, watching the news and try to take a break and take care of myself and get outside. But sometimes it's just like, I can't keep up. So. And then lastly, the resources. Provided a lot of great links here for you. And there's more. I could, have several pages of resources, and it gets a little overwhelming at times. But these are key resources that are good evidence-based documents for you to refer to rather. The 2020 QPP Final Rule FAQs, Quick Start Guide, talked about that a little earlier, improvement activities, the new IA that was just released for COVID. They also have a Dear Clinician letter. It's pretty nice. It gives more specifics on the objective. And then the data validation criteria, great document. You go in there and it tells you what you need to prove that you're doing your improvement activities, what to keep in your audit file. And then CMS has a list of telehealth services that just they approved 80 additional services or ENM codes for as of April 30th. So there's a link there. And then the CCHP, which is Center for Connected Health Policy and Telehealth. This is pre-COVID, but they just released this awesome guide back in January of 2020. So a great resource if you want to get up to speed on everything telehealth. And then Medicare, as of May 8th, all these things are happening so fast. There is a Medicare coverage and payment of virtual service, a YouTube video. I provided it's about 23 minutes long. It's a quick watch. But it's pretty good, so I highly recommend checking that out. And then AMA, American Medical Association, has this awesome playbook that was, again, released in early 2020. And this is post-COVID information, too. But a lot of good stuff, just like that, the CCHP, billing for telehealth, the AMA, good stuff, and I trust it. And so just something for you to check out. And then CMS press release on April 20th. There's a link there for the COVID clinical trials. And then our most gracious host today, the Upper Midwest Telehealth Resource Center. There's a link to their site as well. I mean, this is just, I couldn't fit everything on one page, but they have a menu of great resources for you. And they're for the Midwest, so Illinois, Indiana, Michigan. It's constantly being updated. A lot of great stuff. They have webinars that they've hosted in the past. They'll have the slides and the recordings available. A lot of good templates in there for you to use, consents. Maybe you're looking for the right verbiage to use within your practice. Highly recommend this website. Good stuff. And then, of course, as mentioned earlier, great place to go to too. If you don't have this as your favorite, CMS has made it so much more user-friendly, not only for MIPS reporting and everything, a lot of great stuff. So you click on About, and it brings up this little menu, and you go to the resource page, and you can search for things at that site. And then last but not least, these are some contact helpful sites for you to go to here at Purdue. We have the Medicaid and EPs and Medicare hospitals. We have the Medicaid help desk, listed our email and phone number. And then for Medicare or MIPS providers, we have the Indiana help desk. If you have a question, a lot of the stuff can be gray and you need some help. We've listed our hours there. Reach out. There's no cost to ask a question. We're more than happy to help you. And we have a lot of great people here at Purdue that are excited to, we do this stuff daily, and we're kind of geeks about it. So it's a good place to reach out to. And then lastly, like I said, I told you to strap on, questions. If anybody have a question, I believe you have to unmute yourself if you want to, or type it into the chat as well, if you have any questions.
Yeah, thank you, Patty. Oh my goodness, it's such a whirlwind trying to keep up with all the changes that are going on these days. Thank you so much. I'm sure people will want to take advantage of downloading the slides and listening to the recording again once we get it posted. So now is the time for questions. If you are all joining today's webinar, you are in listen-only mode. So take a look at the bottom of your screen, click on that Q&A, and start typing away with those questions. As we mentioned at the beginning, we are recording today's session. It will be posted on our UMTRC YouTube page, and we will also put a link on our UMTRC archived webinars page along with the slides. I'm going to ask you to go ahead and, Jeanette, put your question also into the Q&A instead of the chat function so that we can track those. But there's a question, any bonus points for public health reporting and for MIPS?
No bonus points per se for public. I didn't do a deep dive in light of time on the public health objectives, but I did include a link to the public health objectives. Let's see if I can go back to that one.
Okay. You want to point something out on a slide there for that?
Yeah, I'm kind of going back to see where they were. Anyway, but yeah, no bonus points per se. Okay, so here's the public health for MIPS. You have to report 2 different public health agencies or clinical data registries for any of the following. So you have a list of 5 to choose from. For Indiana, you're automatically excluded from syndromic because our state just doesn't do syndromic. So if you're doing data registry or public health registry, electronic case reporting or immunizations, any kind of those, you can. And there is some folks it's just out of their scope for immunizations, but there's no bonus points per se for public health reporting.
Okay. Next question from April. Does Purdue expect RHCs to be able to continue using telehealth? And when do you expect that information to be published? That's a crystal ball question, isn't it, Patty?
Yeah, no doubt. We don't know, unfortunately. Like all telehealth, we're hoping, I mean, CMS, Seema Verma has said, I've been on a lot of webinars as Becky's, I've been on some of Becky's and some other providers are really hoping that that the patients see the value in this long-term, not only patients, but providers. They've gotten used to it. I had my husband a couple weeks ago had an appointment with his provider, and instead of having him to leave work early and rush to the doctor's office, he sat at the dining room table and had an office visit on his smartphone with his provider. And he loved it. It was so, he was more at ease, relaxed. Of course, there's things that you can't do via telehealth, but for rural health clinics, long-term, your question, we don't know. We're hoping. we're hoping that things post-COVID, that the government commercial payers and Medicare sees the value and continues on with reimbursement for us. So.
Now, I will say, and April, I'm not sure what state you're from. If you're from Illinois, Indiana, Michigan, or Ohio, your state Medicaid program did allow for you to be both an originating site and a distant site for your state Medicaid program prior to COVID. And Medicare prior to COVID allowed you to be the originating site, so the patient could be at your site. So I'm happy to talk more about that if you have more questions. Autumn, would you go ahead in the chat and put your email and my email as well? And I think Patty's going to show us her email.
Yeah, I've got my contact information. Oops.
There you go. Whoops.
Oh, I jumped out. Oh, let's go back here.
So what additional questions do you guys have for Patty today?
And and I want to mention too, if you guys, after the fact, I know sometimes after I get off a webinar, like, oh, I wish I would have asked that question. Send me, here's my phone number, my mobile phone number, and send me a question. I didn't put my email address in. It's prose@purdue.edu. My apologies. I'll tweak that. But prose@purdue.edu is my email. If you want to shoot me an email, I'm more than happy to try to answer your questions. And yes.
And then since we are federally funded, we usually ask folks to fill out a short webinar survey. And I think Autumn's got that link. If she doesn't have it handy and put it in the chat, then we'll include it in our follow-up email as we start getting things out to you guys from today. So I don't see any other additional questions, but Patty, I want to say thank you so much again. You're just a wealth of knowledge. From now on, I'm calling you if I have a MIPS question.
Hey, I'm here for you. Thanks, Becky.
All right. Thank you, everyone. Have a good day.